thank you everyone for coming on time. I'm sorry I didn't start on time, but I'm not even sure how to do this next time, but fortunately Jackie was here. So I like to do a case-based learning. Dr. Haroon, welcome. This is a 53-year-old woman with chief complaint of neck pain and bilateral upper extremity paresthesias. When you ask her the distribution of the paresthesias, she said it's all of my arms and all of my fingers. So who's the best spine expert in this room? It's probably Dr. Greco. I'm Mr. Greco. Mr. Greco, if someone says the entire hand, what nerve roots could be involved?
5, 6, 7, 8.
Yeah, you know everything. I mean, yeah, so you're smart. So then, now what's that? Come on, he's smart. His symptoms, he's had it for years. She had an anterior cervical discectomy infusion with the Peak ROIC system, which is sold by Zimmer Biomet. Inside of that, she had I factor, and we're going to go over all these things for fusion. It was 18 months prior to presentation. I put the date there, but you don't need to know, just 18 months before. And she said she did very well. And then I said, well, did all of your symptoms go away? And she said, yeah. And she said, when did they come back? She said, about 6 months later. And she said, I could not stop taking the meloxicam because I have chronic pain in all my joints. And my doctor said, that's why I never healed. So let's go around the room and everybody can state one reason why you can get a non-union. What are non-union risk factors? Who can start? We'll start with Emma. What things do you know that cause non-union? Okay, that looked at your head. Maybe you don't want to start. We'll start. It's okay. We'll start Ruth because Ruth knows everything. Osteoporosis is a mild one. What else? What's the most common one? Smoking. Yeah. What else, guys? Huh? Diabetes. Yeah. Okay.
NSAID use.
And yes, NSAID
Yeah.
definitely. The classic NSAID that we use to stop heterotopic ossification and hip replacements. Guys,
Indomethacin.
you get indomethacin, methotrexate, and Celebrex is the easier one on the stomach. Yeah. Okay. So that's not bad. Now she had poor wound healing. I mean, poor bone healing, and the surgeon also put her on an ultrasound bone stimulator post-op. And I don't know. I guess things were okay, but then her symptoms recurred. And her past medical history: bipolar, bilateral ligation, total knee replacement. Medications are Cymbalta, lamotrigine for her bipolar disease, Zyrtec, meloxicam. Left-hand dominant. She's divorced. She has a grown child. She's applying for disability. She worked as a clerical. And her height and weight's 5'7" and 190 pounds. Is pretty reasonable height and weight. So, is there anything else that anybody wants to know about this patient that you've asked in the clinic or exam? Am I missing something? Because I learned from you guys. Something? No. Okay. So, who wants to describe the findings on the X-ray? Somebody's got to volunteer. Max knows everything. Okay, Max, he knows everything. But go ahead.
So it looks like there's on the left side, there's a standalone ACDF from 4.5, 5.6, and 6.7. Which looks like it's attempting to heal with osteophytes anteriorly.
Yeah. How about posteriorly? Do you think you see osteophytes?
A little bit, yeah.
Posteriorly, maybe, right?
Yeah.
Maybe, right? See that and this and this.
Those two levels.
Yeah.
So yeah, maybe posterior as well. Do you think there's a fusion or a non-fusion? Can you tell? What do you guys think? What's the best way to see if it's fused? What's the
Flexion
best test?
extension.
Oh, yeah, yes. John, you are so smart. Okay, I'm gonna just go right to there. Okay, so what do you see here on the flexion extensions, John?
What's that?
What do you see on the flexion extensions? I measured it too.
Well, you're looking at the gapping between the spinous processes.
Yeah, the gap between the posterior spinous processes, and here's the flexion, and here's the extension. And it looks like there's motion, right? Because here there's a distance of 18 millimeters, and here there's a distance of 14 millimeters. And between this one's 14 millimeters, next one's, that one's equivocal. But this one, the bottom one is 27 millimeters, and the bottom was 19 millimeters.
Wow.
So it's moving a lot, right? And it shouldn't be moved if it's fused. So I think, like John said, this is basically, I would say this is a non-union. And so let me ask a couple other questions. Do non-unions cause pain? Let's say you had a femur fracture, didn't heal. Can it cause a source of pain? Yeah, right?
I would think so in a long bone.
Yeah, when you're trying to fuse it. So what if you do an artificial disc replacement? Is that considered a non-union? I don't know the answer to this question. What does the people think? Because this is the same thing as a artificial disc replacement, right? There's motion, there's an implant in there. Why would this be painful and an artificial disc replacement not be painful? I don't know the answer. I have a theory, but I don't know the answer.
Well, the artificial disc is done to promote motion
Yeah,
through the segment,
yeah.
whereas you're trying to limit the motion through the segment.
You want to fuse it, right? So what's the difference? I mean,
You have like vasculature and body's trying to heal it, so it has like nerves and stuff that are grinding. And moving.
I think there's something to that. I'm not sure of the answer. I'm not, so let's just go back. I have theories on non-unions and I don't know if I'm right or not. You guys can tell me if I'm wrong, but whenever you do a fusion, patients never have pain, and the pain always comes back about a year later. And why would the pain come back a year later? How do you get pain? Like if I stab Max with a knife, how do those impulses get to his brain? It goes up, right? The afferents go up, and so you have pain afferents, right? And what's the fibers that feel pain? Yeah, the nociceptors and the small thin myelinated P nerve roots. So that you need that to feel pain. If you don't have that, you don't feel pain. You're insensate, right? So my personal theory is that when you do these surgeries, you strip the nociceptors to the area, and then those nociceptors grow back, and it takes about a year to grow back, and that's why patients have non-union pain, I think. What do you think, Ray? You're the expert. You're you know more than me.
I don't know. I mean, I
What do you
kind of
think?
like your
Is
theory.
that plausible?
Yeah, I mean,
Okay.
I like your theory of.
All right, you don't want to get
Like it takes about 18 months for nerves to regenerate and
yeah,
sensory nerves, and you're using the cautery right on the bone. So,
yeah.
so you injure those nerves and they grow back.
I don't
mean-
know. Do they grow back on artificial discs? I don't know.
So, I mean, I think motion creates osteophytic formation, and that's why a lot of the disc replacements fail, is because
Right.
you got that constant motion in those osteophytes. And I've seen a lot of failures where they come back or they didn't do well initially because they're doing, like disc replacement theoretically would work great for a soft disc herniation, but if there's any like neuroforaminal narrowing or bone spur formation, those patients tend not to do that well.
Yeah.
So
What do you think, Oren? You agree with that?
I mean, I agree. I just, I think it's a question mark.
Yeah, I don't think anybody knows.
I don't know that I've thought about this question. Why would a disc replacement not hurt long-term, but a non-union would hurt?
Yeah, I have no idea.
Interesting question.
Unless you remove so much bone, I guess, and so much of the osteophyte that it doesn't, I mean, you
In the
think,
lumbar spine, you've messed with the facet joint. So if there's a non-union of the lumbar fusion, I can see the facet hurting because you purposefully stripped the,
it grows
facet,
back,
but they're
it
not
grows
putting
back.
it. Is it maybe because with a fusion, you're messing with the uncovertebral joints, you're stripping them out, and they're the ones that are hurting? I don't know.
I mean, I don't know the answer. I'm just curious because like if this was an artificial disc replacement, this is like a home run. Like, hey, we got great motion.
With the disc replacement, you're putting that portion in between them, like bearings, to kind of promote the motion.
Yeah.
But with the fusion, you're leaving the bearings out, so you're just going to get that constant grinding, right?
Well, this thing looks, I'm going to show you what this is.
but you also have to think about the inverse. That is, I've seen hundreds of patients with non-unions. They're all asymptomatic, or a lot of them, 80% are asymptomatic. They have no.
You see the symptomatic ones, though. The asymptomatics don't go to the doctor.
Yeah, but you see them and you're
It's
like.
common. It's common.
Yeah, I mean, it's very like huge percentages of, like, I rarely take back non-unions unless they're symptomatic, and of those that are symptomatic, but anyway.
Yeah, it's a very interesting topic, and I don't think, I don't know, no one talks about it.
Patients or what?
Okay, so let's go over the Zimmer Biomet ROIC system. So it's made out of PEEK, polyether ketone, which is like, I call it plastic. I mean, and it has these metal stays. You can see them that go in. I'm going to show the video. And you put the bone graft in the middle here, And, Max here, he's an investor, so I thought it would be fair to just share Zimmer Biomet ZBH Max. It's $20 billion company. And you see the,
I think
today,
Zimmer was just bought by some other company for a ridiculous amount of money.
Zimmer was bought?
I think
Yeah,
so.
they were bought by, these two Italian, you know, the
Bogus?
brothers that do the Coflex, it's an
Yeah.
Italian name.
But I just looked
New
it up.
York
It's still a public,
Private
it
equity.
hasn't happened yet. Must have not happened yet.
No,
It's
no,
still,
I
you
think
can still look it up.
Yeah, it probably hasn't happened yet, but
Yeah, it's
Yeah.
20 billion. Its
yeah.
PE is 12.
Yeah.
It's based out of Warsaw, Indiana. Has anybody here been in Warsaw, Indiana?
Been through it.
Have you?
I have, yeah.
What's it like?
I'm gonna tell you. And, the Zimmer spine market share is 6%. The biggest is Medtronic, as you can see. Anything else you want to know about Zimmer Biomet? See, that's Warsaw, Indiana. You see where that is? Warsaw. Now, Warsaw, Indiana is like the home of all orthopedics. Do you guys know this? Okay, do you know why? I'm gonna tell you why. Because of Reverend Depew. Reverend Depew was a pharmaceutical salesman in the 1800s. And he created Depew Orthopedics to sell this thing. It's a fiberglass splint. And it's kind of like the progenitor of what we use. It's soft, you put it in hot water, it gets hard, and it was to replace casts. And he created a whole company. He died from a heart attack, unfortunately, kind of early when he was 60. 61 is not too bad, I guess. But back then they didn't have healthcare, so he started the whole company, and then people left the Pew and started their own company, the Zimmer. Everything's based out of Warsaw, Indiana, and I went there as a resident to learn about the factors implants. So let's just go over. I think when you take out implants, you should know how to put them in too, so you can see what the blades look like, and you distract it through this system, and then you insert it. And part of this is you don't remove this posterior osteophyte. So I think this works best if you don't have a ton of osteophytes. And I think what's novel with this system is the blades. The blades are really easy to deploy. Let me show it to you guys. They put the implant, that's kind of standard. Can everyone see this? But see how the blades go in? And then you just push them in.
You just tap them in.
So you see, you just push them in, and then they go, and they kind of stop it from going forwards and backwards. Stamp it in. Does that make sense? Okay. So, and you put the bone graft in the middle of the implant. It's kind of standard. Okay, everybody good with that? Okay, so I'd like to learn about these about things. Okay, so polyether ether ketone is what the plastic thing's made of, and we use them in spine all the time, but they also use them in transmissions, aerospace, and airplanes, and in automobiles and transmissions. And it's very strong, and it's very strong with heat, and it doesn't wear very well. It's a very strong thing. And what's I factor? I factor is a peptide. It's the P15 peptide, and it has calcium in it too. And I factor basically, do you guys want to see the 2-minute video? What it is?
They're gonna show it.
Oh dang! It can't. It's not playing the. It's not playing the audio. Anyway, it's a peptide, and it's a small peptide, and it's what osteoblasts join onto, and it recruits osteoblasts. This little peptide, it recruits osteoblasts, and then it also helps differentiate osteoblasts. So the theory is this P15, the osteoblasts will come out of the vertebral body because there's nowhere else where they'll come from, and dedifferentiate, and then start laying down bone. And there's calcium in the I factor too, and that's how it works. So it's kind of interesting. It's kind of new. And I use this. I use the cortical cancellous allograft composite, which is kind of old school. And I'll tell you why I use, when I do the fusions, I use this, is I like the footprint. I think the footprint is bigger. And so if you look at the footprint of a cage, the plastic doesn't fuse, obviously. It's just the inside part. So I just feel the footprint is bigger. But I mean, I don't think it's that much helpful, but that's why Max always asks me, why do I do things? So I just feel there's a bigger area to fuse. You imagine two blocks, if you have glue, you'd want the larger area than the smaller area. Okay, so let's go back to our case. So here's the MRI. Who wants to describe the MRI? Someone who looks, Max, why don't you do it? With John, the last one. How about sagittal cuts, Max? What's all this black stuff? Is that normal?
Could be artifact from the,
Yeah, it's artifact thrown off by the implant, right?
yeah.
And, but just in general, how do you think of the area for the spinal cord?
Actually looks relatively okay. You can see CSF around most of the spinal cord.
Yeah, you see CSF all around the spinal cord and all the views, and on the sagittal cuts in the front and posterior. And this hole, you have to tell Emma, this hole, what is this hole for?
That's the frame that's for the nerve root.
That's the framing, okay. And what lives in the hole? In the framing?
Dorsal root ganglion.
Yeah. And what if there's, now look at this hole here. This is C5, C6. Would you call it big or small?
Small.
Looks kind of small, doesn't it?
Yeah.
So then the dorsal root, tell Emma what the dorsal root ganglion is. Why is it painful?
It has a lot of pain fibers in there. So if there's osteophytes protruding posteriorly in it, they can press against the dorsal root ganglion and cause a lot of radiculopathy pain down that nerve root.
It's part of the nerve root. So that's what we're suspicious, right? So now let's does anybody else want to describe the findings? Is it just John and Max?
Did she have, I think she had some like myelopathic changes in the spinal cord? Is that because it's just those limited cuts?
Yeah, maybe, yeah,
The
maybe, but
white streaking in the spinal cord?
I don't think she did, but I see what you're saying. It does look like there may be some spinal cord signal change, but she's not myelopathic.
Okay.
And centrally, I think the area is good. So what do you see here on the obliques, John? Tell everybody.
I mean, you see the implant a little higher up, but then you look at the posterior osteophytes with a neuroforaminal narrowing.
So here's the neuroforamina, and you see the osteophyte here. And what else is this called? This is the joint of blank. Joint of Luschka, yeah. And it's also called the uncus. So why would this be growing big and pushing on a nerve?
You have movement there.
Yeah, there's motion there, yeah. That's because it's a non-union. And it's and it looks like there's line going all the way across all three levels. So how about John here on the sagittal cut here?
Yeah, so you're looking to see if there's any bone bridging through the disc spaces,
Yeah.
which you don't really see.
It's hard to interpret because you could
Some of the
potentially,
scatter. From
yeah,
the-
you could have it could be artifact, and you could have bone going through here because you don't really see a black line through the implant.
6-7 looks very suspect. Down.
Yeah, so it's difficult. It's difficult with the, and I'm going to show you another case. So here's everything all together. This is what me and Max, we put it together before the case. So this is just it's an article on the P15 peptide, and that's from 2024. So I gave you guys two articles to read comparing ACDF with a plate and without. This is from 2018, where it was a meta-analysis. And there's 15 studies, like 800 patients, and the plate had a slightly higher fusion rate. The standalones had a higher substituent rate by a lot, 21 to 49%. Dysphagia was better with no plate, which kind of makes sense because you would think the plate would cause dysphagia. As far as neck pain, the plate did better. As far as arm pain, no plate did better. And then this is a more recent study, 2023, where they did case controls. They matched everybody, a matched case control at one hospital. And they found it was similar. The plate had a slightly higher fusion rate, 89%. The standalone was 85%. So it was slight improvement. And the repeat surgery was slightly more with the standalones. But the repeat surgery, like 14%, is like really high. Like I never have to revise my I mean, I never revised my ACDFs. So it's weird that the revision rate's so high, it's weird, but maybe they're doing difficult cases, I don't know, high risk patients. Okay, so here's, who wants to do this one? Here's a case of mine that I just saw in the office, and Max, we're gonna have to do his surgery soon. So this is November 2014 and March 2025. So there's 3 levels of fusion. And who here used to watch Sesame Street when they were growing up? Anybody? You guys did not watch Sesame Street? You watched Sesame Street? Yeah, because you're a similar age.
Yeah.
Do you remember the game? Which one is different? Which one is not the same? So which one's different? Which one's not the same? Which one is different? Which one is not the same? Which level is different? 9 years later. Now it's time. Anybody to play a game? Don't you think the bottom one looks different?
Yeah.
See how the screw, the bottom screw where it is in 2014 and the bottom screw in 2015? See, the bottom screw has 2025 has a big osteophyte in the front, and it's not there on the left. All the other ones went on to fuse very nicely. So this is a case of a 3-level fusion with a non-union at the bottom. And the patient presented with cervical radiculopathy symptoms. And here are the obliques. And I thought there was some motion on flexion extension between the posterior spinous processes. See how the posterior spinous processes are more together here than they are there? So he has a non-union C67. And on the oblique, you can see the line going across the disc space. So this is a non-union from a plate. And the thing is, when you use the allograft, 9 years later, it's like a solid femur. There's no artifact from any implant because all there is bone, and the bone gets eaten up by the body, lays down its own bone. And if you use a corticocellulose allograft, you can clearly see the non-union. That's one thing I kind of like about it. I can see my non-unions. So this is a non-union from ACDF. Okay, so let's go back to the case. What do you guys think we should do with this patient? Cervical radiculopathy, foraminal stenosis. So we'll ask Ray and Oren. Ray, what would you do in this case? Go through the front, go through the back, do both? Like, what are your thoughts?
I mean, the beauty of the neck is that if you approach it one way and you fail, you got the other way. So usually, if you can't go in, I mean, if you've done it anteriorly, it's always nice to do fresh territory and go posteriorly. So
Yeah, so you have to avoid the scar, the esophagus, dysphagia.
yeah.
So
So
you just do posterior.
yeah, probably posterior decompression, fusion,
Laminectomy,
foramenotomies.
no laminectomy, foramenotomies, no
Probably
foramenotomies.
foramenotomies. I don't think he's got much spinal stenosis, or the patient doesn't have much spinal stenosis. Yeah.
Just foramenotomies. Okay. Will you use iliac crest or no iliac crest?
I mean, if there's no bone, I'd use iliac crest, and posteriors tend to fuse pretty easily if you draw up the set joints.
Cervical
So,
fuse pretty
yeah.
easily in general. This is unusual. I've never seen a 3-level non-union. I've never seen a 3-level non-union. Yeah. What are your thoughts? What are your opinions?
Oh, definitely go posterior. I mean, if this, like, there's great data. If you do a 4-level fusion, it's recommended to back it up in the index case posteriorly.
Circumferentially, yeah.
Although I've done 4-level standalones also, but still, having a non-union, doesn't necessarily mean that they can't fuse. It's just this particular patient needed a little more stability. So I think if you fuse posteriorly, it's still a high chance for fusion.
And you avoid all the risks in the front of the neck. And it would be it would be difficult to take those out. Remember what a hard time we had Max the other day trying to take one out? It's not easy. You have to remove a lot of bone, and you're up against the esophagus and the scar. It's difficult.
It's really no benefit. I mean,
Very marginal benefit unless you really have to. Okay,
Yeah, the complications are definitely higher.
yeah, more
So
complications.
what would be the indication for taking it out then, just like infection?
the implant had migrated posteriorly, and the implant's causing itself a problem.
Yeah, infection would be one, yeah. Implant itself causing neurological compression, and you have to take it out. Any other questions or comments, or anybody else would do anything or about what we should do with this patient? No? Okay, so, let's go over the foramenotomy technique, because, this is something I created a long time ago. So it's just the anatomy, and people used to call it a keyhole foramenotomy. So you can see that's what we want to get to. That's not a perfect cartoon, but it's pretty good. And it's basically a circle, and you can see there's blood vessels close to the nerve root. And this is a sawbone that after the foramenotomy, and you can see the medial portion of the facet has been removed. And I'd like to get some centrally so I can see where the dura is. So in my mind, in my opinion is, I want to know where things are so I don't injure them. So I find centrally, and then so I know where dura is in my head, and then I go laterally, and I find the V where the lamina connect, is where I start, and I'll find the lateral portion of the facet. And if you look through the central portion of the spinal canal, you can see the superior articulating process of the facet. That's usually our villain. That's usually what's compressing the nerve root, the superior articulating process from the inferior level. So you can see the uncus, it gets hypertrophic and it's compressing the nerve root as well. But you don't do anything to the uncus. See the uncus or that's an uncus too. It's black and it's probably cortical. You don't remove that. You remove posterior. So if you need to remove the uncus, it's not going to work. A posterior decompression. That's what it looks afterwards. So hold on. So the blue is the nerve root. I put a blue thing. So the first thing we remove is the inferior articulating process of the facet, and there's nothing really there because the superior articulating process is deep to it. So you can do that kind of quick, and then more inferior portion of the facet, superior articulating process, I usually try to do sort of like an L just to stay away from the dura. And just sort of hopefully lift the whole thing off, but it's never successful. But you see, I'm kind of doing an L and then trying to get as deep as I can. And then at some point you see like a lucency, which would be the dura. When you see a lucency, you know you're real thin. And that's what's nice about doing it with the microscope is I can't see because I'm old. So the microscope helps me see. And also Max can see too. Max tells me, I think you're in a good place because Max is young. He's got better eyes than me. So that's why it's good to have the assistant talk to you. And then once you get to that point, and you're looking at dura, you have to be careful. Obviously, I don't hit the nerve roots when I do the case, not on purpose anyway.
Does she use a kerosene deeply or do you use it
Yeah.
probably?
Yeah, a kerosene, and a curette. So then I'm going to rotate this, so you can see that's where then you see the nerve root coming down, now the vertebral artery is deep. I spin it, so the vertebral artery is deep to the nerve root. So I don't think you can get the vertebral artery from this approach because you'll hit the nerve root first. So the nerve root basically tells you to stop. That's your stopping point. And you can see how the nerve root has more room now. See how the nerve root, it can drape posterior. And you don't need that much room, you just need a couple of millimeters. Does anybody, Ray or Oren, you want to comment anything I said wrong, or would you want to add something?
Yeah, very good.
And then you can just feel, I don't feel with a ball tip probe, but I feel with like a 2B curette to make sure there's like plenty of room. You want a little more room than the nerve root itself because when the patient moves the arm, the nerve root moves too. You want to have a little more room so there's no further stenosis. And if you're going to fuse it, you can open it wide. You don't have to worry about post-op instability. But I think if you just do one level, it's not a big deal too. Okay, anything else for,
How much of the facet do you usually take, or how do you know,
I mean, about half, but I try a little less than half and see what it looks like. A little
you
less
feel
than
the
half.
pedicle or?
I try to feel the pedicles, yeah, above and below. And I use the pedicle as like I use a micro nerve hook to feel the pedicle so I know where it is in my head all over. So the classic, teaching is the pedicle above and below. You're good. Okay. Anything else about foramenotomy? Okay, so this is what I did. This is the artist's depiction of the frame. Actually, I think I did a laminectomy just to make the foramenotomies easier at that level. And on the left, she did not have 5 nerve root type symptoms, so I did not think I had to do the left C4, C5, but I did all the other framings. And the surgery was 3 hours, 45 minutes. It's kind of long because the foramenotomy is for me take time. And I think I used iliac crest. And it went fine. I used screws. I used lateral mass screws, kind of standard. And the patient did great. Arm symptoms totally gone. She did have a lot of neck pain afterwards, axial central neck pain, which mostly went away. So I was surprised how well she did. Because she had a lot going on. She has bipolar disease. So I think mental illness obviously clouds things. So it's hard to, you can't expect a perfect result, because obviously the brain is very important in management of pain. And someone who suffers from bipolar disease, but her bipolar disease was well controlled on the medications, so she did well. So I think that's all I have. So any questions or comments?
Did you put pedicle screws in C7 or lateral mass, or what do you do at C7 usually?
I almost always do lateral mass. Unless the C7 looks more like a T1. Like some people look more like a T1. Because that's gotta be a bullseye. I mean, if you're off lateral, you hit the vertebral artery. If you're off medial, you're in the spinal canal. I mean, really, do I really want to have to get a bullseye on everybody? So unless I absolutely have to, in which case, if I absolutely have to, I feel the medial wall of the pedicle, and that's how I do it with the pen feel forward. Then I know I'm not medial. But I only do it if it looks like a T1. Like if it's a big, when I say that, I mean it's large diameter. There's no vertebral artery immediately next to it, and some people do look like that. And
So say this was a disc replacement as opposed to a standalone device, would
Non-union.
you approach it differently? It was like a 2-level.
no, I think this is what you would do. I think foramenotomy infusion, kind of standard. I mean, that's the main reason why people do artificial discs. They say you can always do a posterior foramenotomy infusion post-op if you fail. I don't do artificial discs, but I'm not sure who I am. Like if I'm, the story like Max Planck and the physics, like Max Planck, when he came out with these new physics theories that he had, nobody agreed with it. And the field only changed as people died. So as the old physicists died, the new physicist said Max Planck makes more sense than the old physicist. And eventually, over the course of 30 years, everybody agreed with Max Planck's theory. But the old physicists would not change until they died. And so I'm wondering if that's me, if I'm not doing artificial discs, and then when I die, like
I do artificial discs, but I think the points you raised are important. I mean, you can't do an artificial disc as an equivalent procedure as an anterior cervical fusion. For the disc and disc replacement, you need to make sure the patient doesn't have pseudarthrosis, the patient doesn't have instability, that you do address the decompression appropriately. If you do a disc replacement, you can't compromise on other things. And if you compromise it, maybe you're getting paid by the company, so you do disc replacement everybody, you're going to have lots of failures. The other point I wanted to raise, we touched on this infection. Whenever the classic teaching for non-unions or pseudarthrosis is to rule out infection. And you do that by symptoms, either fevers or chills. Is going to get a white count, a pre-op. We don't always get CRP. It would be reasonable to get a CRP in the SR in this kind of case. I don't know that I always do, but that would be very reasonable. You get imaging to make sure there's no fluid, abscess or anything. That always have to consider that for non-unions.
no, that's a good point. What else? What other comments, critiques or anything?
Have you guys seen many infections
How would
through
you get a
anterior cervicals?
Very uncommon.
Or how would you biopsy? Would you biopsy to get a specimen in this case? It would be difficult.
Yeah.
You'd have to open the neck.
I mean, I think you have a good sense based on symptoms, imaging, and labs. You'll have already a good sense about infection. I say that, but in other parts of orthopedics, they like even post hip replacement, pain. They even with minimal symptoms, people will get biopsies and aspirations. We just don't tend to do that.
It's been a smoldering 12-year infection, right? I mean, you did the surgery back in 12, so it'd be pretty unlikely.
Yeah.
Over 12 years that.
It's unlikely, yeah.
Well,
And so the anterior cervical is like you're saying anti-cervicals just don't get
I've never
infected.
seen
It's-
one.
Very, they do, but it's rare, very rare. They can. When they get infected, it's a disaster.
What about, I have a random question about dental work and fusions and stuff. You advise them on any sort of,
I don't think there's good advice, I don't think there's good evidence for antibiotic prophylaxis for after any orthopedic surgery.
but like,
Really
how
great
would you
questions.
recommend the patient not get like dental work or significant dental work for a certain period of time?
I mean, I don't think there's any good science that tells us the answer to that. A Gestalt feeling, yeah, one can say, don't do it for 2 or 3 months, but I don't know that that's well.
What's your policy? Because patients call.
I say it's up to your dentist.
You're gonna deal with.
I'll tell you, mine is no dental work for 3 months and everybody should get antibiotics. I don't prescribe them. I let the dentist prescribe it. Tell the dentist has to do it. What is your, how about Ray? What do you do?
3 months, no dental work unless it's an emergency.
You're afraid they may see the implant,
Correct.
you know?
Yeah, so for
Yeah.
3 months. no
Antibiotics?
dental work. And then, I say usually no antibiotics, but that's based on, talking to the ID guys. They're like, oh, you don't need antibiotics.
You guys say you never need antibiotics.
That's true.
And the patient goes crazy.
Yeah.
And if they get infected,
You're
we gotta
really.
explain it. Yeah. I'm like, well, the literature, I'm infected. Why don't you-
One dose of amoxicillin, I don't think it's gonna.
I mean, I've had a patient in ICU post-op from C. diff that I gave the patient antibiotics. So, and it was an old person. I'm more uncomfortable, I'm more hesitant with like an 80-year-old getting C. diff because that patient does get sick. What are you gonna say, Rick?
So when you say go to your dentist and have them prescribe it, how does that usually end up?
They do it. They do it. They do it. You know why? They're motivated to do the procedure. They do it. The dentist is motivated. He try to pushes it off because they don't want to take the responsibility of the antibiotic and all that. I don't know why they do that. And they know the flora of the mouth. That's bizarre.
What about pre-op dental work? How would you feel if your patient was going to get their teeth cleaned the day before your surgery?
Well, that's
Our patient.
that's not
So
good.
you tell them, how long before do you not want them going? Same thing, is it about?
What's your policies?
I mean, I didn't even know that, like, that's not even.
It's not.
Wait, I had a pretty detailed checklist. I gotta add line 27A to my.
Oh, wait.
Yes.
Well, let me tell you another thing I learned. John has a policy, every joint has to go to the dentist and get teeth
Get
pulled.
dental clearance.
Because everybody has bad teeth in his office. Everyone has to get all their
Special
teeth
patient
pulled.
population.
Yeah, 2 or 3 teeth pulled, typical. So he said everybody,
Mouth first.
yeah, everyone has to go to the dentist. So, my policy is 2 weeks, like you gotta wait 2 weeks, teeth cleaning, wait 2 weeks afterwards.
Do you have a checklist for dental?
No, I don't. How about you, Warren? You have a dental cleaning
I
policy?
try not to think about these things too much. I would agree, at least 2 days not to have teeth cleaning. I don't think bacteria stay in the bloodstream for weeks though, so.
Yeah.
If someone asked me, I would tell them not for a few days.
Yeah, but I've had cases, my case is canceled because the anesthesiologist, like, this patient has like a tooth abscess. You can't do it.
Mhm.
That's
Certainly, yes, if that's.
Yeah.
So if a patient is a smoker, how do you process their intake? Like, do you test them and stuff?
I don't do fusions on smokers unless they cry a lot. If they cry the whole time in the office, I just usually break down and just do it.
Especially if they're women, right?
Yeah, if it's a woman and they're constantly crying, I was like, oh, all right, I'll do
It's a
it.
guy, you're like, get out of here.
Yes, guy, yeah, go to hell. You gotta quit smoking, jerk.
Come on.
What is your policy smoking?
I tell them to stop smoking and I encourage them to stop smoking. And, if they can, if there's a neurologic deficit, I'll do it. But, if they can, then,
If it's elected.
I mean, I encourage them. Sometimes they don't.
How about if you really want to, he's a smoker, but you want to be sure they quit? I have a new policy that I do. I check for nicotine.
Aetna's starting to do that just this past year.
Yeah, I think Aetna made me do it. I was like, you know what? I'm gonna start doing it.
Yeah, Aetna.
I'm in the OR
This
today. so
past
someone
year,
else
just
has
a
that.
month ago, I got a case.
Yeah.
You need a negative nicotine before we'll approve it.
Yeah, Aetna told me, now I'm starting to do it. I was like, okay, they're like, I'm gonna quit, and everybody lies. So I'm gonna check your blood. I'm not gonna post a case until you're negative.
I gotta get out of here.
So And I've done it, so it's like, you're still positive, was I quit, well, whatever. And then I said, I'm gonna check you the day before, just to stick it to it, I'm gonna check the lab, but they know I'm checking.
Okay.
And then, so by then, if they've got like 1 month off cigarettes, you would think that they can continue.
Right.
And I think they usually do, because I think they usually continue to not smoke, because the surgery hurts so much, they're like, oh, I don't wanna do this again. And I emphasis that you're gonna need it again if you start smoking.
Right.
Oh, it's,
So what else? Any other comments or questions? We're almost done.
thank you so much.
All right, thanks for coming. Thank you for coming.
Appreciate it.
Good, interesting questions. Anything else?
You too.
I want to do one thing as a wrap up is, everybody has to say one thing they learned from the conference, just from me. We'll start with Emma. We'll go from young to old. I mean, like experience wise.
All of this I learned.
You gotta say one. You gotta say one.
How to do the plating.
Plating
Yeah,
or the
the
interbody?
disc.
Interbody.
inertia,
Okay.
Yeah.
All right, let's go around the room.
Um,
Ms. Ruth,
your MRI, I'm terrible with MRI reading.
you learned from the MRI reading? Okay. Let's go around the room. One thing.
How you measure the distance between spinous processes on flexion and extension.
Yeah, I learned that from another orthopedic surgeon, always look for that. Jackie, you maybe nothing.
I was gonna say the same two things, but, I guess the, idea that if you're going back in, the preference would be to do posterior, since you have that option.
And a failed anterior,
And if
yeah.
failed anterior, go posterior.
Yeah, I learned I should be more cognizant that it could be a chronic indolent infection. I would get that. Non-unions. Next.
I would say your theory on the pain from non-union.
Oh, that's just a theory though.
Yeah.
That's until somebody can explain it better. Yeah. That's my theory, because I was thinking like, why do non-unions hurt, you know? And then they don't hurt for months, for a long time. And then they start hurting. Like, and the other thing is like, I'm starting to hurt now, my back, and I'm wondering, do I have a non-union? All right, let's keep going.
You know, I think that was an interesting take on, why they develop pain. And then I haven't heard the joint of Wushka for quite some time, so.
Jordan Lushka's great. You're gonna have to spell, can you spell it?
Like Luschk.
You know what I mean. Ray and Norm, you guys are senior citizens. I don't know if I should ask you guys, unless you have one. You can
I liked your emphasis for the foramenotomy, cervical foramenotomy, your emphasis on the villain being the supraarticular process. I'm going to very much keep that in mind next time I do these cases.
Yeah, somebody taught me that.
Yeah.
Right, how about you?
Next clinic, I'm gonna look up what, why do the statements, so.
Oh, and there's another issue. So, you know where that's relevant is dynamic hip compression screws and gamma nails. So now, does anybody do dynamic hip compression screws here for femoral neck fractures, intertrocks?
No,
No, right? No. And I was the first person to do a gamma nail here at St. Agnes. It was new because I learned it shock trauma. And nobody did gamma. They're like, what the hell is a gamma? Why are you doing a gamma nail? Short gamma. It's not going to work. I was like, no, it works great. And the old guys never do it. And as they're getting older, they're kind of like, all the young guys like, I'm never doing dynamic hip compression screws. I do gamma nails. And now nobody does dynamic hip compression screws. Remember?
Yeah.
For a while, you're probably around. The older guys were doing a dynamic hip compression screws.
They did them all the time at.
Yeah.
Shock trauma.
Yeah, and then the young guys did like gamma nails, way better. And the dynamic hip compression screw's dead now because all the old guys are retired. And everyone does gamma
And
nails.
the only ones that I see that get those, is the young femoral neck. Or, the young intertrope.
Specific weird, yeah. Well, they used to be blade plates.
Yeah.
In my day. All right.
Great, well, good job, Sue.
All right, thank you, guys. Thanks for coming.
Thank you.
Thanks for coming and participating.